Okay, so welcome to those of you joining us today. We're delighted to bring you this webinar entitled Innovation in Healthcare, Heart Failure, Digital Health and Wearables. And this is brought to you by the Arrhythmia Academy. I'm delighted to be joined by my colleague, Professor Leyva, consultant cardiologist from Queen Elizabeth Hospital in Birmingham and Professor of Cardiology at Aston University. And we are both really delighted to have our dear colleague, Professor Martin Cowie from King's College London and the Royal Brompton Hospital from London alongside us today as we're discussing this really important and timely topic. Martin is chair of the Digital Committee for the ESC, and recently they had their second annual summit. So this is particularly timely. And over to you, Martin, to introduce the topic.
Thanks very much, Jonathan and Paco. And a really interesting topic it is. And to a very large extent, digital is the new normal. This is not the future, it's happening now. And some very interesting trends going on that have been massively accelerated, of course, by COVID. And you will all have heard the term tech acceleration when 10 years of change happened in just a few months. So the NHS, along with other organizations, can be innovative, can be fast-footed, and change very rapidly. And thankfully, the technology was there to support that. Now, as we come through pandemic to endemic, it will be interesting to see where this all lands. So some key themes I think that we'll be discussing this morning. And one of them is that remote consultation is now very normalized into practice. I think it will always be part of the toolbox that we use to interact with our patients. So probably not worth discussing that very much. Remote monitoring, on the other hand, where you collect physiological information, and for heart failure, of course, can be a huge amount of information. A lot of difficulty in showing added value from a lot of extra activity, a lot of extra information. And that really kind of bleeds into the wearables area, where in theory, at least, patients can use a whole range of technologies, lots of clever engineers. It's easy to get the data back to us, but can we make sense of the data? Do we make better decisions or just more decisions? Is it worth all of that disruption? And many people think that machine learning and other techniques that underpin artificial intelligence will support that process. So the patients living on their own, supported by their technology, machine learning would identify when they need some input from healthcare. Healthcare would swoop in, rescue the situation, and then back to where the patient is center using technology. A lot of concerns around this and lack of demonstration of value here, but that seems to be the future. So it's very exciting. But the last point really is a lot of people either think that AI is like, gold dust. You just sprinkle on a problem and the problem goes away. And then there's others that think that AI is a mark of the devil and that it's just going to destroy cardiologists and others' jobs. But I saw in a podcast from the medical futurist recently where he actually said, automation won't replace physicians, but those using automation will be replaced by those that don't, or the other way around. So you see what I mean? It's about all of these different things happening at the moment, lots of moving pieces. How do we navigate this as cardiologists? How do we identify what's good from what's just fashionable? How do we get the evaluation, the evidence into place? How do we get reimbursement and the healthcare system to line up behind it? How do we educate and support not just our patients and their families in digital and health literacy, but also ourselves and our team? So it's a very exciting time, and the future is definitely going to look different, but digital is already here and having an impact. Just a few comments really to start the discussion.
Fantastic. Thank you, Martin, for that overview. I guess let's start with a topic that's close to all three of us, heart failure patients, and how we treat that. I'd be interested in knowing your views on the implantable monitors. I know that you've been involved with CardioMEMS as an example, an implantable pulmonary artery monitor as a way of detecting early deterioration in heart failure. And I just wonder whether you think with this acceleration in wearable data, whether we'll be at a point whereby the implantable monitors will actually be taken over by the non-invasive wearables, and whether they'll be able to give us the same data, and whether COVID's allow us to almost jump over those implantable monitors to something non-invasive in a much shorter space of time. What do you think about that?
Yes, in theory, it's a great idea, and it can make for some very nice PowerPoint slides. The problem is in the reality of the situation where we've had for many years the ability to telemeter multiple streams of data. The problem is, as I hinted at, is extracting the sense or the information from the data. And I think we are getting better at that. I think regulators, reimbursement authorities are also very interested because in theory, it's a great idea and it should liberate healthcare professionals to focus where they can add value, it can support and reassure patients. A recent study, just one example, Boston Scientific, with its MANAGE-HF algorithm, the FDA said it sounds really sexy, sounds great, but you've got to go out and demonstrate that when you give it into the hands of normal healthcare facilities, it actually translates into better outcome for patients. Then you come back and we'll consider that. And I think it's this demonstration of value that's hugely important. The example you showed of CardioMEMS from Abbott, certainly for the sicker end of the spectrum, we've even shown in the UK with Coast HF, which is coming out in ESC heart failure in the next week, that 15 NHS centres could use CardioMEMS at a massive reduction in rehospitalisation rate. So it can work when there's a data stream, when there's the humans there to look at it, to make sense of it and to act on it. Because the final part of my answer is about, it's all very well having a flag for risk being high. One, if you can't change that risk, or secondly, if patients are not willing to change what they're doing, they're not willing to increase their diuretic, they don't want to do this, they're feeling fine at the moment. In other words, thanks very much, doctor, but I'll just do what I'm doing. The whole chain breaks down. So it's not just the tech, it's the whole chain of the human factors as well, and supporting the people within that chain, including the patients, to change what they're doing in response to the data. Quite a complex phenomenon. I think we're getting there, but I don't believe that we're going to suddenly have a new era where wearables will replace what we do in heart failure services.
Okay. And I think actually you raise a really important point about workforce actually, because we all have a challenge in having enough workforce for all the data coming in, and you talked about that as well. And I think that can be a real issue with too much data and noise from data. Maybe we'll come on to that a little bit later with wearables. Paco, I just wonder, from your perspective in treating lots of heart failure and device patients, have you found an increasing use of either apps on the phone or digital health apps from the companies, and how have those influenced how you treat patients on a day-to-day basis?
So actually, I mean, the whole reality has changed because of COVID, actually, and the arguments surrounding the use of wearables and implantable devices has also changed because of COVID. Previously, we had debates about cost effectiveness and all sorts of practical issues, but the reality is that we have to use them. That's how we've got through COVID, maintaining patient safety and being able to monitor patients. So we've actually increased the uptake of telemonitoring from 15% pre-COVID to 98% now, and we've done that over a period of 9 months. In addition to that, we're doing up titrations, all up titrations remotely, and that in fact has proven to be much more effective. And together with that, we rely on blood pressure monitors, all sorts actually, including telephone apps. Not all of them are great, but they are better than nothing. And obviously for difficult patients with difficult problems, we still see face-to-face. But this is all transformed. There is a lot of noise, as Martin was saying before, that half the problem is sifting all the false positives, and that is here to stay. So I think that any artificial intelligence filters that we can use in order to cut down on the false positives would be great. Overall, I think this is a very positive thing, actually. And I had my reservations about telemonitoring before, but given that we have to use it, we've used it, and my experience is very good, actually.
I think that's a great and a very good position to be at, which is saying that digital is not something that's separate from usual care. It's a tool that can be used and blended in where it's appropriate. And I think this idea that every heart failure patient needs to be monitored from the get-go to the rest of their life is a nonsense. Many patients on good therapy become very stable and very expert in their condition. And actually they can probably, if they need to, self-monitor with very simple tools. There are others, of course, where it's very challenging to get stability, and that's where remote monitoring and different things can come in. And it may come in and then come out, come back in. So I think this idea of consciously deciding what the plan should be, what we're trying to achieve, and how can we support that? Is it telephone calls, as old-fashioned as that? Is it digital technology? Is it remote monitoring? That approach of kind of a conscious decision between the patient, family, and the healthcare providers, I think, is that mature position that we need to get to, and we need to use the tools that work, and we need to get help to navigate, to be told which tools work and which don't, because at the moment there's a lot of shiny toys that keep getting thrown at the wall, and often they don't stick. It's really trying to identify what works well. And to Paco's point, COVID has completely changed the conversation. It's much more acceptable for patients. They don't feel they're being fobbed off with non-face-to-face contact. They quite like it. They see the convenience. But there's other times where you absolutely have to see the patient face-to-face, particularly in complex heart failure. And I love my final comment. I love Paco mentioning blood pressure monitor. That ain't new technology, but it's fantastic technology for up titration. Why didn't we do that before? Why did we force people to come up and for a nurse to do the blood pressure? For goodness sake, that's so medieval. So it's great to use the relevant tools at the relevant time to achieve what we're trying to achieve.
I think that actually beautifully moves us on, Martin, to digital health, telemedicine. And actually that was going to be my next question to you both, really, which is, how do we find the right blend between face-to-face and digital and remote? COVID clearly made us overnight change lots of consultations to remote. And now we find ourselves in this post-COVID era, which I suspect will last for a while. It's not going to be a few month phenomena, whereby we're trying to readjust and we're trying to figure out what the right thing for our patients is. And I think there's also a lot of blaming COVID for how things are now. And actually, I think what we need to get away from is that discussion to the one of, actually, this is the new normal. What is the right thing for our patients? So my question to you is, how do we decide what is the right blend? Which patients for you both are you seeing face-to-face? Which ones are remote? And how should we change that in the future?
I mean,
well, I'll take a first stab at it, shall I? And just say that let's ask the patients. It's about supporting them to achieve what they're wanting to achieve. And I was speaking to a whole lot of the Pumping Marvelous patient educators. So they've been listening to patients across the country about this. Many of them, if they're stable, are very, very happy with remote monitoring, remote consultation, as long as they can navigate the system and get back in if they feel things are going in the wrong direction. Happy with that. What they're not happy with is difficult conversations done over the telephone, where you've got that lack of empathy, you've got that lack of picking up on body signals and body language. That shouldn't be done like that. I think that can be cruel unless it's absolutely essential. That should be done in a human way. I think also for very complex first patient, new opinion, second or third opinions of very complex issues, you have to develop rapport, you have to examine the patient, you have to use all of the tools that you have. I think that's extremely challenging to do remotely. But once you've developed that rapport, then that's an option. And I think one has to make sure that you ask the patient. You can make assumptions. Oh, this patient's 80, they'll prefer face-to-face. Not at all. Maybe they absolutely don't want to come to a hospital. This patient's 25 and work in the IT industry. They'll definitely want to do a video call. Absolutely not. They don't trust video calls. They're not happy with it. They want to come and see you. So from my perspective, it's about having a range of things and having a conscious decision-making rather than a policy that you run through your program, irrespective of the staff and irrespective of the patients.
That's really interesting. Paco, how about you? What's your feeling on this?
I think we have to, in a way, modify some of the clinical guidelines that we've developed before. For example, in NICE guidelines, we have that every patient with suspected heart failure needs to see a specialist and have echocardiography. Now, we have been forced not to see those patients who have an echo that doesn't show that it's not consistent with heart failure. We no longer see them. So patients with a high BNP sent by GPs who have a normal echo, we no longer see them, unless, of course, the GP insists. Now, this is not really in the spirit of NICE guidelines, but I'm afraid that we cannot do that. As a result, actually, we have been picking up and being able to concentrate more on patients with systolic heart failure, some diastolic heart failure, but really taking out of our service patients who may have conditions that are easily treatable in general practice. Again, in the NICE guidelines, we have, the need for in a way, it was understood, face-to-face examinations, etc., which we cannot do. So we now have about 1,000 cases seen from last September that have been treated remotely, and we've looked at the safety of this, and we have had no untoward events at all. So we have been forced away from some of the guidelines that we've developed in the past. And I think this is here to stay. We're going to have problems with healthcare and capacity for the next 3 to 5 years, I would have thought. So I think maybe we ought to put this in clinical guidelines reflecting the new normality.
Yeah, I guess there's another question about the digital literacy of the population that you serve, and that may be different up and down the country, but I'm sure both of you, could also reflect on those challenges, and that's probably something that I guess will not be solved in this conversation and is something for local authorities and government, but something that I've found treating certainly different populations and moving from one area to another is that there is a vast difference. And like you say, Martin, it's not about being ageist. The 85-year-old can be very adept with technology and using video calls, etc., and the younger person isn't necessarily as digitally literate as we might assume. So how do we, as physicians who are advocating for the patient, try to ensure that we can have the technology, the infrastructure available? Because we all know how expensive and challenging that can be for hospitals to institute, and it won't happen overnight from a couple of Wi-Fi stations across the hospital. So how can we be an advocate for change in that respect?
Yeah, and obviously multi-layered problem, isn't it? But UK is in a good position. Actually, is very much trying to get very fast broadband everywhere. And I can see now that when people buy homes, it's one of the first things on their list that it has to have access to ultra-fast broadband now, more than a garden or 3 bedrooms. So it's very interesting to see how society changes. I think it's not just about the patient's digital literacy, it's also about our team's digital literacy and supporting them to work in different ways. The way that you do a remote consultation is very different from face-to-face. It's very different on the telephone versus a video call. So I think it's about this concept. In fact, we're just auditing I'm doing a register of digital and health literacy amongst heart failure patients at the moment with ethics approval, because there's so much written about it, very little published, lots of assumptions made. How do people access information? When do they access the information? Why? Were they ever signposted by a healthcare professional? Usually not. How long do they keep going back to it? Very seldom do they go back more than once or twice to the same source of information. How comfortable are they with many of these tools? So I think this is about co-design. It's not about us deciding what's good and throwing it at people. We have to sit down with the key stakeholders and work out how to navigate this space. But we're in a good position in the UK because actual health literacy and digital literacy is not too bad in the UK. Very patchy, to your point, Jonathan, so you mustn't make assumptions. But also, if somebody is not digitally literate, you don't have the time to help them get there, they don't want to get there, don't force them to use a digital tool. You have other things that you can offer to support them. So it's that personalization that I think patients are really appreciative of.
You agree with that, Paco? You have similar issues local to you?
Yeah, no, absolutely. I mean, I think another thing that I'd like to add is that although we are all very keen to be progressive and to use telecommunications, etc., this is in a way not proper medicine because you will talk to patients now, and the great majority of patients actually want a face-to-face consultation and that human interaction with their clinician. And we mustn't forget also about examination and the visual cues that you get from a consultation that actually patients may not tell you about at all. But the way that patients walk into your consulting room, the expressions and everything else. So I think we have to resist any sort of blanket guidance to replace our interaction with patients with telephone or video, because in my view this is not really proper medicine. We have to incorporate the examination and the human contact. It's going to be a difficult balance, but no doubt we have to be selective and pick those patients who need the face-to-face consultations the most.
I can definitely reflect on the need for that amongst patients who I'm referring, for example, for catheter ablation for AF. And I think that for a while, certainly with COVID, we were completely remote. A lot of organizations were. And I think a lot of us felt uncomfortable with the fact that we might have been referring patients that we hadn't seen, and the need that we really felt we needed to see them, that end of the bed test, all of the multiple senses that you get, eyes, ears, etc., and all of the clinical acumen that you bring from your clinical experience. You kind of I think we forgot how important that was, and so I'm glad that we've now, I think most people reinstated those face-to-face appointments. Like you say, they're very, very important for specific conversations, as Martin said, and for suitability for cardiac surgery, cardiac procedures, or anything really.
But also,
okay, well, that's.
Yeah, I mean, that human contact, a lot of the work that we do is reassurance. Patients want to have to meet you face to face and to have your reassurance, and your facial expressions and the way that you interact with patients actually is very important. To reassure someone on the phone when they don't see you, when it's not the same.
Yeah, it's interesting to see how it will play out with patient-initiated contact, which is the kind of NHS England policy now, where instead of us deciding when we want to see patients at set intervals, etc., which often doesn't bear much resemblance to their need, this idea that you have more expert patients, they then contact you when they need to be seen, it's more efficient, you have the capacity to see them quickly. I think in theory is a good model. I think for heart failure, it's quite challenging because many people actually deteriorate without really noticing. It's a very gradual process. So I think all of these things are just tools. So I don't think people should brand themselves as I'm a digital enthusiast or I'm a digital Luddite. It's actually, how can we be the best and how can we have the most positive impact for people with cardiac disease? And we have a range of tools to help us reach out and reach in with our skills. And hopefully we'll end up using our skills where they have maximum impact, and the tedious automatic type stuff can be taken away either by machine learning or other staff groups. And we then focus on where we need to be there, and we can use our skills that Paco's saying. It's medicine, it's a blend of science and art and humanity. And that ethos has to continue. But at least now we've got more tools to use it so we can reach people much further away than we used to be able to. So I think it's exciting, but I hate it when everybody's polarized into digital and not digital, etc. It's not like that now. It's a very blended approach that we're moving into.
think it's exciting how far we've come and how that acceleration's occurred over COVID. I think probably all of us are happy with that. Not obviously happy with COVID, but some of the fallout has been positive. I guess that moves us on nicely to wearables, an area probably every cardiologist up and down the country is astutely aware of. I can reflect on the number of conversations, emails and calls I've had from patients thinking they were going to drop dead because their Apple Watch or Fitbit told them their heart rate was 40 overnight, and having to have the conversations about the vagal tone and the mammalian system, and that actually that's quite normal in pretty much everyone. I don't know about yourselves, but that has been a significant amount of work just for myself from the conversations I've had. So I guess wearables are here to stay. That's probably not a question, but how do we manage all this data? And how do we filter it? Because it's clearly causing a lot of work and not all of it good.
Well, this is what happens when the availability of this is not subject to any form of regulation or rigorous scientific assessment. That is not to say that that there is a lot of science behind all of this, but they're not regulated, and there is resistance, of course, from the industry for any of these things to be regulated in the same way as devices, medical devices and pharmaceuticals, etc. But this is going to happen, what is happening already, so we have to cope with that. Yeah, the pulse is a problem. The number of patients with bradycardia who are completely healthy it has certainly gone up. I think the biggest pain is actually the saturation, which of course is very easy to measure with most wearable devices, but in the number of patients coming with problems with desaturation down to the 60s and that sort of thing, which is of course not compatible with life. There must be a glitch somewhere. I think we have to work towards again doing some more science and perhaps regulating some of them, actually, despite the resistance of the industry.
Yeah, it's a challenging
Martin, how have you found
field.
Sorry.
Yeah, it's very challenging, and we all get swamped with some individuals that get obsessive about their recordings, and often then they're technically not high quality. So it is difficult, and that's where I think the joint discussions with regulators, with policymakers, with the tech developers is to try and find a solution to this problem. I think it's also about managing expectations with patients, saying it's fine if you wear an Apple Watch, but don't expect an immediate response to every single thing that comes up on it, etc. And I think also a responsibility of those doing studies that, sometimes it's great to get a nice paper in the New England Journal and it seems like large numbers, but actually it's not a population in need, for example, at very low risk. And even if you do detect atrial fibrillation for very short periods of time, it's probably of no clinical significance for the vast majority of people. So really, we've got to match the investigation to the needs and then come up with solutions to this. I think we shouldn't do, of course, though, is just rubbish the whole field and say there's nothing in there. Obviously, there will be, but it's very difficult to see value from just noise and processing the data, etc. That's got to be automated. It can't be down to humans looking at every single piece of information. So machine learning, I'm sure, will have a big part to play there. But we have to make sure that we then limit what's happening by those like ourselves, so that we don't get swamped with low-level, low-impact activities, as opposed to using our time more appropriately for maximum impact and value. So I think the yin and yang of that will play out over the next 5 or 10 years. Everybody's aware of the issues, difficult to know where it's going. But last comment on it, it's interesting to observe what happens when patients choose a technology, come in to see a physician or nurse and show it to them, almost slightly hesitantly, saying, well, I don't know if you want to know, but I do this. And then the physician or nurse look at it and they're kind of hesitant themselves, going, well, I'm not even sure I want to have this conversation. Show it to me. No, never seen it. You keep it to yourself. I'll keep my technology, my data, my side of the desk. You keep your technology their side, and let's just pretend that we're in a parallel universe. I'm not sure that's a really helpful approach to this, but it is jolly difficult for everybody, patients and physicians, to navigate what's good in this space. It'll be interesting to see how it plays out in the next 5 or 10 years.
Yeah, I think there's a lot to be said about how that information is filtered. And I do worry, I have to say, I really do worry about the amount of noise and the impact on the workforce, certainly for us in the UK, and I'm sure the same elsewhere. And how that impacts upon our workforce and how we're able to manage that, because I think it was a real issue with the implantable loop recorders that recently have become smaller, more miniaturized, and implanted in a less surgical way as an implant, and we've seen a lot more noise from them, and I suspect we're going to have a similar problem with the wearables. I guess just to come to some conclusion really, and forward trends, thinking about the ESC Digital Summit, which was recently completed. How do you both feel about where we go next? There's obviously a lot of Me Too studies out there. There's a lot of people publishing on large amounts of data. That's informative and useful. But how do we as a community move forward so that we can actually positively impact upon patient care? Like you said, Martin, at the beginning, there's some very nice slides that can come out of digital health applications and pictures and clip arts, and that's great. But how can we actually move the conversation forward so that we can really impact upon patient care? And what are the trends that you've seen recently presented?
Well, I can tell you from the ESC point of view, we've kind of got a 5-year vision for this, and we wanted to set up the Digital Summit where we could have discussions with all the stakeholders, patients, tech developers, regulators, and cardiologists and the cardiac team together about creating the future. And what are the unmet needs? What's technically feasible? Where do we get value? What's the downsides as well as the upsides? And I think having those mature conversations with everybody in the room is very helpful. We've also set up our own journal, European Heart Journal Digital Health, and that's to shine a light on the work. So to say we need to have evidence, we want it, there's not digital exceptionalism. Just because it's digital doesn't mean it gets a free ride. So trying to raise the standards of discourse around this, and a little bit more communication between the engineering world and the health world, because often they don't connect very well. So that's the thing. And the third strand is about education of everybody working in cardiovascular care and patients as well. And that is about digital literacy, but it's also about asking the right questions. It's not just about the technology itself. It's about what we're trying to achieve. What's the role of medicine versus social care versus self-care, etc. What consumer versus patient activation, all of these topics. And that's more a societal discussion. But I think it's good if we take part in that as an active contributor, rather than just cardiologists speaking and moaning to each other. It's about seeing that we're just part of society. What role can we play? So that's from the ESC perspective, but I'd be very interested in where Paco thinks where we should be going as well.
What do you think, Paco? How do you feel about this in terms of the future, how we move the needle?
Well, I think we have to embrace what's coming to us. It's going to happen anyway, whatever we say. But it's important to note that none of this technology replaces a clinical decision. The bottom line is that you have to have a proper clinical decision at the end of it. The other thing I think is that clinical guidelines need to look at each device in turn and make recommendations as to the validity of the outputs from all of these devices, and perhaps some regulation. I wouldn't insist on regulating everything, because it's impossible to do that, but I think sooner or later we will need some sort of regulation. I think my overall impression of the past 18 months of COVID actually has been very positive. Paradoxically, it has increased our efficiency we're concentrating on patients who really need heart failure specialists and device therapists as well. And we have been much more selective. The bottom line, I think, is that we have to embrace it, and we have to make our clinical decisions understandable to the public when they report things like, a sinus bradycardia or the occasional ectopic or whatever.
Yeah, no, thank you. I think that's really helpful. One final comment that I would make just before we close is that I think it's also incumbent upon us as physicians and allied healthcare professionals to be actively involved in the process. I think something you mentioned, Martin, is that often I find as the end user, or one of the end users, the other is the patient, we are often last to sometimes see technology after it's been iterated multiple times. And there's so many companies out there and startups that I think create technology apps, prototypes without even talking to a patient or a physician, and they often find themselves way too far down the line. And I think it's incumbent upon us to be involved in that process and get our hospitals and our universities and our academic institutions involved at an earlier stage so that we can develop those innovations in-house and improve them. Okay, fantastic. Yeah. So Paco, you want to close and conclude? I think this has been a really exciting half an hour to chat with you all.
Well, I agree. I mean, I think it's we all concur really that we should embrace new technologies. We should try and put out opinions as to what we really think about this and what steps need to be followed in order to make them reliable. At the end of it, we're trying to make a diagnosis or a self-diagnosis with whatever gadget. But it's important that we bridge the gap between all of these devices that you can buy off the shelf and what to do with your bodies. And I think our role is to buy into that and to provide advice. And again, I think we also agree that we should have more involvement from clinical guideline groups about specific gadgets. I think that's it. And then overall, the only other point that we've touched upon is that actually the COVID situation has taught us a lot in a way. I think that patient care at the moment is much more efficient than it was, certainly in heart failure. And that was unexpected.
Fantastic. Well, thank you both very much for your insights. I think we covered quite a lot of ground actually, but hopefully the conversation will keep happening amongst clinical communities. So thank you both for your time. And for those of you watching, I hope you found it useful and instructive. Thank you very much.